In January 2024, the Saskatchewan Government announced they will be bringing more treatment spaces to the province. Many of these spaces will be run by Edgewood Health Network. Jamie Miley, the Director of Government Relations at Edgewood.
I mean, the work that's being done now by people in addictions in Saskatchewan is absolutely heroic, but they need help.
And Vice President of National Operations, Christina Basedow.
Treatment can't just be about stopping the substance. It has to be about so much more than that.
Join me on the podcast to talk about what this means for our province, because change is coming. But is it good?
Because I really fundamentally believe that harm reduction is a pillar of substance use programming.
What's up, everybody? My name's Dan, podcaster, public speaker, and advocate, and this is Hard Knocks Talks, your addictions podcast. Jamie, how long have you been working in addictions here in Saskatchewan?
I've been working in addictions in Saskatchewan for a decade.
And why did you get into it? Why do you care?
Well, I had my own struggle that you and I have talked about, and I was fortunate enough when I needed help to get it. And I see other people, particularly in Saskatchewan, who are struggling, that did not have the kind of break that I got. What were some of the options available to see that people who were suffering were able to find the help they needed, and a high level of quality care that we've maybe been lacking here in Saskatchewan. I mean, the work that's being done now by people in addictions in Saskatchewan is absolutely heroic, but they need help.
What do you think the biggest changes are going to be as far as what we have now been offering and have been for the past number of years compared to what's coming with Edgewood?
Right. Longer inpatient care, for one thing. There are opportunities too for intensive outpatient care as well. That will be introduced. But I think people think that, and it's true, longer in treatment, the better the outcome. That's a statistically proven fact. If Edgewood is now going to offer 6 to 7 week, 45-day treatment in Saskatchewan, that's only part of it. What Edgewood is actually, which HN is actually offering, really is a year. Because after a person is discharged from inpatient, they get an aftercare person in their hometown to work with them for a year after. Plus, there's ongoing programming that EHN offers that will help people, once they get out. Pardon me. Yes, they'll have this toolkit, as we've all heard. You get this great toolkit. What are you going to do with it when you get out? They help you use the toolkit. And that is maybe the piece, I think that piece has been missing in Saskatchewan. And so...
So do you think, and just briefly, so do you think that the aftercare portion of what Edgewood will be offering is possibly the most... what's the word I'm looking for?
Differentiator?
Yeah.
Partially, because I think the other part that a huge part of what Edgewood will be offering is the medically assisted piece at the front end. So there will be detox services offered, and there will be also constant medical care up to and including psychiatric care, PhD level psychologists, master's level counselors, really professionalizing what's being offered to the still suffering addict.
Let's bring in Christina. Christina, thank you for joining us today.
Yeah, thank you for having me.
What specific needs are you seeing here in Saskatchewan that may be unique to our province?
Well, the main thing we're trying to focus on is really digging in and giving people an opportunity to seek out bed-based care and really have the option to do inpatient treatment that is a longer duration than some of the pre-existing sort of 28-day programs or even 21-day programs. When it comes to what's really on the ground in Saskatchewan, we have seen a lot or really have gotten quite a few anecdotal reports and also reports from people struggling around the crystal methamphetamine usage and obviously obviously, I mean, the fentanyl crisis is something that is talked about a lot, but really just seeing a large amount of individuals struggling with really intense addictions,
Mm-hmm.
and also the psychiatric comorbidity that comes from that, right? So the usage of things like crystal methamphetamine really impacts how the brain operates,
Hang on one
and
sec. Let me
it's really
interrupt you.
degenerative.
Let me interrupt,
Yeah,
and I apologize, but
no, it's
explain
okay.
comorbidity. You use big words on the show, you're
Yeah,
gonna get called out.
sorry.
Even
Sorry,
if I
yeah,
know what
sorry.
they mean.
You know, yeah, so comorbidity really means like there's multiple existing struggles at one time, or
Uh-huh.
multiple existing challenges that are present. So in this case, you'd have people that are cross using different substances. You'd also see a huge comorbidity or connection between
Uh-huh.
different types of addiction issues and mental health diagnoses. So a lot of
Mm-hmm.
people using substances to either treat an underlying condition, so really seeking out substances to try and mitigate some challenges, or having mental health really deteriorate because of the use of substances. I mean, we could get into the chicken and egg on that, but
Mm-hmm.
you see a lot of those two things existing at the same time. And it means that treatment can't just be about stopping the substance, it has to be about so much more than that, because there's so much happening for individuals. And
Mm-hmm.
then you kind of layer on top of that, that when someone's actively in addiction and potentially, in a disenfranchised situation, they're also going to be exposed to really pieces that impact them, like trauma and other, violence, or really just the general lack of being able to take care of themselves, and those things will all layer on top to add more to the issue, right?
Mm-hmm. So, do you have a target demographic in mind? Because I know different demographics, maybe people who have resources, people who don't have resources will have their own unique challenges in accessing services like your own. So, is there a target?
The base target is anyone struggling with active addiction, to be honest with
Mm-hmm.
you, who's 18 and over. So 18 and to an unlimited age on the other range. When it comes to that, though, we do have some factors that we would look at that would expedite someone's getting into treatment, right? So individuals that are coming from a housing insecure situation, individuals that are maybe struggling with like some challenges in their housing or challenges in other access of social supports,
Mm-hmm.
individuals that, if we have people that are pregnant, or individuals that have young children that might need to be expedited into treatment,
Mm-hmm.
obviously cultural factors as well that may play into that, but really looking at anyone that would be struggling that's going to ask for help. And it can come in a range of to your point, socioeconomic backgrounds, a variety of backgrounds. And then depending on who's coming in for us, we're going to basically layer treatment based on that. And we have this really awesome ability. Jamie mentioned length of treatment earlier, where we can decide how long someone stays to us, ranging anywhere from 8 to 16 weeks. And if we look at the average substance use program, somewhere varying between 21 and 28 days, having 8 to 16 weeks to help individuals that we determine need that level of care is exceptional. And it really
Mm-hmm.
changes the game for how well someone's going to do in treatment, but also how well someone's going to do when they leave.
Hmm. So tell us a little bit more about what your programming looks like specifically. And I know you mentioned a few minutes ago talking about working with people with crystal meth struggles or the opioid crisis or anything. Now, is there a difference in the way that you would help these people, or is your programming like the same? Like, tell us, is there spiritual components?
Yeah, great question. Loaded question. So I'll do my best to answer it. Really, honestly, it's not a cookie cutter program. We're going to work with individual differences, and I can talk a little bit about what that means. When we talk about the type of substance that someone is using, it's going to impact potentially their detox, the length of detox, whether someone's going to go on medically assisted therapies after their detox and continue on those even post treatment. That would vary. For example, opiate use versus crystal methamphetamine primary usage would look different in that regard.
Mm-hmm.
The type of treatment, though, captures a huge amount of different areas. Like, we're obviously medically stabilizing individuals. People have access to 24/7 nursing care. That's a big piece. Also, access to doctors and psychiatrists when necessary. But additionally to that, we also have sort of the really intense case management, really addressing things from a recovery oriented systems of care perspective, where we're taking into account a term called recovery capital. What's the access that this person has to external resources that will help them, and what's happened in their life through a biopsychosocial assessment that we do at the beginning that really might speak to the type of therapies that they need, right? Have they
Mhm.
been impacted by a variety of traumas? Do they have developmental challenges? Has their drug use impacted their ability to learn in a traditional way? So we need to change the type of therapies that we use. And so we try to really capture treatment from a spiritual, psychological, mental health, like a variety of models that really are best practice now that we know that you need that integrated level of care, because people don't want to be treated as their issues all being the same, and not all therapies fit for certain people, right? So we really try to use like the variety of interdisciplinary teams to address a lot of the concerns, and then try to build up the facets of an individual that are present to help them before they leave treatment and then into aftercare, as Jamie was mentioning too.
Okay, we're going to take a quick break and then we'll jump right back in.
Okay.
The Advancing Interprofessional Management of Substance Use Disorders in Saskatchewan program, or AIMS-SK, is offered through the College of Medicine at the University of Saskatchewan and is designed to deepen healthcare professionals' understanding of substance use to improve health outcomes for individuals with substance use disorders. This program consists of 3 modules, including the foundations of harm reduction in substance use disorder, opioid use disorder, and alcohol use disorder. If you are a healthcare professional in Saskatchewan and wish to reduce stigma and better serve those with substance use disorder, look for the AIMS-SK link in the description below. All right. Also, if you are struggling with the substance use of a loved one or have tragically lost a loved one to drug-related harms, reach out to Stronger Together Canada peer-led support groups by Mums Stop the Harm. If you are in search of private inpatient addictions treatment, check out Prairie Sky Recovery Centre located in Leipzig, Saskatchewan. If you are looking for help with criminal record suspensions, the Elizabeth Fry Society of Saskatchewan covers all associated costs for women or gender diverse individuals to apply for criminal record suspensions. Reach out to Chelsea at 306-668-0635. To make contact and learn more about all of today's sponsors, to check out our new merch, or if you want to show us some love and buy us a coffee, all of those links are in the show notes below. So how can people access your programming?
We are looking to go live in April, so we're going to be launching a online access point for people to basically send in admissions documents and preliminary documents either online or over the phone, and that can be available by private individual, but also can be accessed, for example, by community resource providers that may have individuals that are looking for treatment. We're going to definitely go live with that once sort of we finalize the timeline of that, so that we're not taking in individuals that we can't actually connect with. And when that comes out, I probably will happily send to you maybe to air as well, but we're hoping to see that go live sometime in March in order to get a wait list going for individuals to access care.
So, and people would call you directly, or are you like, because I know like you're doing this work. I don't know if it's directly with the Sask government or if the Sask government is just sort of funding it. Actually, that's a good question. What's going on there?
Yeah, so really this is really advanced in the sense that it's publicly funded, privately delivered. And so from our point, they'd be calling us directly. Edgewood Health Network would have sort of a Saskatchewan admissions center that we would have, which would have a phone number and also the ability to do online forms for admissions. And then our admissions team would be contacting the individual seeking care, or for example, a family member if they're doing it on their behalf directly.
Okay. I'm interested to know more about your intake process. You make a phone call. Hey, I'm in a bad way. I have a lot of things going on. I'm not good with forms. I'm not good with automated services. All of these things that are typically barriers for what we currently have in place now. Do you have is there help for people to get admission if someone is just completely unable to compute and they call you? Like, congratulations, you called, you made it this far. How do you help them make sure they get what they need?
Yeah, absolutely. So we want to be as barrier free as possible. And to your
Mm-hmm.
point, not everyone can do the online form piece or access those things. So with our admissions team on site, we will be able to help people and fill it out for them, honestly, if they're
Beautiful.
calling in and able to access us from a phone. And some people may be in situations where they just don't have access to other forms of technology, or they only have a phone call from, for example, a shelter that they may be in, or whatever that is. So we will try and make that as barrier free as possible.
And harm reduction. Is there and harm reduction is so much more than what some call safe supply and supervised access and or consumption and all of that. Are there strategies in your program to accommodate harm reduction modalities?
Yeah, on one hand, a loaded question, and on one hand, not, right? Because
Yeah.
I really fundamentally believe that harm reduction is a pillar of substance use programming, and it's a pillar that for many is part of the beginning of their journey to whatever their recovery will look like. As some people will stay in a harm reduction spot, no judgment there. Some
Mm-hmm.
people will take their recovery somewhere else, and everyone's entitled to that choice. And I think for us, when we look at our programming, we're providing, 8 to 16 weeks of medically assisted and also medically supported care. We are foundationally looking at helping individuals achieve the most wellness that they can, but also supporting their choices. So for those individuals that want to be completing treatment with us, they will be engaged in things like medically assisted therapies, which can help individuals stay quite long term in recovery, and has been seen as even a harm reduction technique based on the traditional abstinence-based therapies that were talked about many years ago as being the only option. So
Yeah.
we have a lot more mitigating factors for individuals that come to us and maybe say, this isn't the pathway for me. I don't, this type or version of recovery doesn't feel right. Well,
Mm-hmm.
it's not just like you kick them out and say, well, that's not going to work. Then we would try to engage with community resources and help these individuals at least access a service point that would allow them to carry on their journey in the way that would feel more fitting for them.
So having said that, what would be your benchmark of success? How do you decide we
Yeah,
won this one or not?
I mean, maybe call me a sensitive person, but for me, if someone's leaving our facility and have achieved a better level of wellness than where they were before, like, I already see that as success. I think you have
Yeah.
to be really mindful of how you define it.
Yeah.
I mean, when we look at things like we use a lot of psychometrics, fancy word for saying we measure a lot of symptoms,
Mm-hmm.
and pre and post treatment, and we make those, not publicly available for the individual, but publicly available to know how some people have completed treatment. And for me, any reduced amount of symptom is a win, right?
Mm-hmm.
Reductions in depression, reductions in anxiety, reductions in craving, the ability to be more emotionally regulated, the ability
Mm-hmm.
to feel more in control of
Have
your own
relationships.
circumstances.
Be
Yeah,
productive.
build back your community, maybe reconnect to your spirituality or reconnect
Yeah.
to pieces you'd lost. And at the end of the day, like, the recovery capital scale is a big one too. Like, do you have more access to recovery capital than you did before? And does that help you make choices that are going to lead you to feel more fulfilled in your life? All of
Mm-hmm.
those would be measures of success.
Yeah. So the reason I asked though is because you are working with government funding, the government is going to be like, give us statistics. So when
Yes.
you check the box, we won this
Yeah.
one. What does that look like? What are your indicators?
Yeah, so the indicators for us, we use a host of psychometrics, so a host of different psychological tests that every individual comes in and takes upon entry. And we do those at, like, entry into treatment, midpoint, discharge, and we do that throughout their time. And we also do that throughout their time in aftercare if they're willing to participate in that. And
Yeah.
so they really do vary in what they're measuring. Some of them are the comorbidities that we talked about earlier, which is, have my mental health increased, and what are the symptoms that we've seen? Again, cravings, compulsions to use, general withdrawal symptoms, all of those pieces. So we then provide sort of a report back and say, this is on average where we see, our clientele coming from beginning to midpoint and to
Mm-hmm.
end. And we have really excellent outcomes when it comes to that from a research lens. Of course, that doesn't capture the whole person.
Yeah.
And I strongly believe in the qualitative component of pieces. So we also then have a lot of surveys that our clients can fill in. How was your time in treatment? Did you feel, respected, cared for? Did you feel like your spiritual beliefs were respected? Did you feel like you found something that you were passionate about? And to put that into writing for us so that we can qualitatively also report back on each individual. To your point,
Mm-hmm.
success will look different. And then some of them can be metrics that we can easily deliver on.
So there will be data collection past
Yeah.
the point of leaving treatment.
Yes, for those that are willing, of course, to
Yeah.
stay engaged.
Yeah.
Yeah.
So do you intend, like you mentioned just a moment ago, community partners? Are you
Yeah.
intending on intentionally fostering relationships with nonprofit organizations and community-facing organizations here in Saskatchewan?
Yes, absolutely. I don't think any of us can do this alone, private, public, nonprofit, none of it. I mean, we're all fighting a similar fight, which is really to help individuals access recovery and give people more choice and chance to live healthy lives, right? So for
Hmm.
me, we're actively developing some of those community partnerships already, and also partnerships with educational institutions and universities, and allowing for practicums to take place and for people who are passionate about this work to get in and really also engage in a different way. So I think for us, like the partnerships are going to be multifaceted. And of course, also really open to having anybody in the community reach out to us if they're interested, which if you already have. So thank you for that, to
Hmm.
make sure that we are developing those networks of care, because when someone leaves us, that's not where it ends. Oftentimes we're transferring people back to other service levels or back even to community partnerships that they've had before. And we want to
Hmm.
make sure those relationships are strong.
So you mentioned that you've already begun to foster some relationships. Can you tell us which organizations that you've already made contact with and are working with?
I don't know if I'm supposed to do that or not, so that's a great
Okay.
question. I'd say there's a few university partnerships that I could speak to, especially with nursing departments and
Mm.
some of more diploma-based programs for students that are highly interested.
Hmm.
We've had some great partnership conversations with the Saskatoon Tribal Council regarding their work. We've had some really good conversations with other community organizations that we're trying to pursue, and also really wanting to engage when we're located and settled in with also community that are surrounding us, to ensure that engagement isn't just with organizations but also with community members that are going to be local to the sites as well.
Hmm. Okay, that's all I got for you. Is there anything else you want to throw in before we let you go?
No, just super excited. If that wasn't clear already, we're really excited about
Yeah.
providing this service and helping so many individuals that we haven't been able to help so far.
Okay. Thanks so much, Christina. I'll
Great.
let you go.
Thank
Take care.
you. All right. Take care.
Bye bye. Jamie, um, what would you like to see moving into the future? What would you like to see that would supplement this program?
Well, it's one thing, and Christina, you just ended the conversation with Christina on a really important note in terms of the community outreach and what we're doing. It's one thing to set up a an addiction treatment center that has a long period of treatment. You need people to actually who know what they're doing work there. So, in terms of the importance of ensuring that people are getting the kinds of education that they need in this field from docs from doctors, nurses, addiction counselors, etc., community involvement organizations, so that they can nurture the addict back to recovery. Those are all really important things to me. And part of that comes from the fact that I did my training down in the United States, and there seemed to be an understanding there that if you're going to have treatment, you have to have people who are getting absolutely the best exposure to the latest kinds of treatment modalities that EHN offers. And so I think that's going to be a critical part of this as it unfolds. And speaking with the University of Saskatchewan, with SaskPoly and other organizations, I think they're very keen on being able to supplement what they're doing now,
Mm-hmm.
and getting even better at it.
All right. Did we hit it? Is there anything else you want to throw in?
You promised me coffee.
I did not promise you coffee. You promised me coffee.
No, you said don't bring coffee. I said I would bring coffee, and then you said no. We've got coffee here.
I did say that. You're right. I did say that. But
Don't.
why are you waiting until now? We had at least 20 minutes before we go live.
Well, I was just waiting.
Just waiting. Okay. Well,
Lovely to see you, brother.
yes. Thank you so much for joining us.
Yeah, you too.
Okay.
Take care.
All right. If you got something out of that episode today and you are not yet subscribed to us on YouTube, please hit that subscribe button, hit that bell, turn on notifications. We go live every Friday morning, every Sunday evening, and sometimes randomly on a Thursday. You never know with us. That's all I got for you today. Thank you so much. Take care, everyone.
Say, this is Hard Knocks Talks.
You want a coffee?
No, I'm kidding.
You didn't even actually want a coffee.
Just thought I'd throw a little shade at you there.